Thank you. So thank you to the organizers for inviting me to give this talk. These are my relevant disclosures, and I do like to be controversial, so just feel free to ask questions and I'll give you my controversial response. So I have the task of going a little bit backwards. So our first session talked about all the significant considerations to be made when you're changing regimens for someone who's already undetectable. And I'm going to go back a little bit and say, well, why would we even want to know about those talks? Why would we even change the regimen of somebody who currently is undetectable? And if we were having this discussion 25 or 30 years ago and we were asking physicians, do you want to change your patient's regimen? The first response we would probably get is, well, the machine's working well, why would we change? And I have limited options, so I don't want to use any of the newer drugs that are out there because I may need them going down the future time. Today our answers are a little bit different. We do have lots of options, so the question is, can we do better for our patients? And just like we all want the new iPhone when it comes out and the new Mac computer, newer might be better, but as well, newer might actually be worse. And so we don't necessarily know until we try it. So what are the reasons that we would actually consider changing the regimen of somebody who's undetectable? The first two big reasons are probably managing or preventing short-term or long-term adverse events and high pill burden. And high pill burden can sometimes mean changing to a completely new regimen, that's one pill a day, or it could be combining the current drugs that the patient's on into a single tablet regimen. Difficulty with food, difficulty swallowing pills can be an issue. Drug interactions can be an issue. Pregnancy is an interesting reason to consider changing regimens because there's two different aspects of pregnancies. There's the first when somebody comes into your office and says, we're talking about getting pregnant, should I change my regimen? And the second is somebody who is on a regimen and has got pregnant and now wants to know if the regimen that they're on is safe and they should continue it. And for that one, the discussion becomes a little bit more complex because by the time they realize they're pregnant, any damage that potentially would have been done in the first trimester has already been done. Cost is another reason. One that I really didn't think about until a few weeks ago was when a patient came in and said, my partner and I travel and we usually take similar pills and we take one bottle for the both of us, and now we're on different regimens, so can we switch so that we're both on the same regimen? So that can be a reason. Hepatitis B co-infection can be a reason to consider changing a regimen, and sometimes regimens are either no longer available. We still have people in Canada who are taking the Nevirapine, which now is become impossible to get, so we're forced to change their regimen. And the treatment goal when we're changing the regimen is exactly the same as the treatment goal when we're starting somebody on a regimen for the first time. We want to maintain viral suppression. We want to enable a good, full, and healthy life, and that's really the goal of HIV therapy. We need to make sure we're covering comorbidities. We need to support mental health, and I think mental health for many of us has become a more significant issue having gone through lockdown with COVID. I mean, I know myself, I didn't really appreciate how important social interaction was, and I can only imagine what it's like for people who are, MSM, for example, 60, 70 years old, no family, no friends, no support, waiting for the phone to ring and there's nobody there to call. And these kind of came out of going through COVID and COVID isolation myself. So I think we have to be very supportive of that and be more mindful of some of the mental health issues related to the medications that we have patients on. We want to continue to monitor our patients for co-infections, make sure vaccinations are up to date. Undetectable equals untransmissible is very, very important, and so that's another guiding factor in regimens that we choose, is to make sure we can keep people suppressed. And then pregnancy and other maintaining life goals, and a new one that's coming to light now is trans health, and both in terms of HIV medications and maybe even a little bit more importantly in terms of PrEP, in terms of anal versus vaginal intercourse and the transmission of HIV, that the regimens become very important. In behind all of this, what we're talking about is the whole process of aging with HIV. And I gave an HIV aging symposium about a month ago, and somebody thought I was going to talk about aging physicians who are neurocognitively impaired with big fat bellies. And I said, well, I meet one of those, but I'm not going to tell you which one it is. But I think it's really important to keep in mind that HIV patients are aging at an accelerated rate compared to the HIV negative population, but they're still approaching relatively normal life expectancies. And we know that if we look at inflammatory markers, and clearly we don't know what markers are important, and we don't know what the predictive value of any one marker is. But if we take HIV negative patients who are otherwise equal and measure their inflammatory markers, we'll call that the baseline. If we take HIV positive patients who are undetectable, their markers are elevated compared to HIV negative. And if we look at patients who are HIV positive who are not undetectable, their markers are even higher. So we know that even if you're undetectable from an HIV point of view, you still have more inflammatory markers than HIV negative patients. And this is important because inflammation has now been linked to be a significant marker in terms of the aging process. And some of that has come out of just natural aging studies, and some of that has been good research that has come out of the whole HIV epidemic. We also know that antiretroviral medications can cause aging. We know about the mitochondrial toxicity of some of the older drugs, which we're not going to go into today. But we do know that HIV medications can cause issues such as lipodystrophy in the old days. And if you looked at some of your old patients who had lipodystrophy back then, we all sat back and said, this guy looks like he's prematurely old. Their skin looked old, they had the lipodystrophy, and so HIV and HIV medications themselves probably cause a premature aging process. So we want to keep that in mind and look at maybe some newer regimens that may not have that inflammation ongoing. And it's also important to look at the social economic determinants of health. Do people have access to health care? Can they afford health care? Can they afford their HIV medications? Can they afford to go see a doctor? So all of these things put together are on the underside, but form the basis of what we're trying to do is to allow our patients to live a normal and healthy life. Now, when we're starting HIV medication, there's a whole lot of things that we look at. We look at their HIV status, we look at their underlying medical history, we look at their T cells, we look and assess their compliance, any barriers to taking medications. And when we're putting people on an HIV regimen and switching them to another one, we still have to do all of those same things again. Nothing is different, but there is one addition, and that is the treatment history, which is extremely important when you're changing regimens from somebody who's on a medication regimen and they're currently undetectable. And so how do we assess and how do we maintain that? And the first thing is to make sure that you haven't made a mess of things by switching the regimen. In our clinic, when we prescribe HIV medications, we give patients a prescription for 1 month with 5 repeats, so they're good for 6 months, and they come in at 6 months and do their lab test. When we switch the medication regimen, we give them a 1-month prescription with no repeats. That allows us to assess them again in a month. We do another viral load at that particular point in time to make sure they're still undetectable, because we probably, if we made a mess of things, we probably haven't made a big mess of things within a month. And if they're still undetectable, then we give them 1 month with 6 months going forward. It's very important at that particular point when we're changing the medications to assess their antiretroviral history. Not everybody gets to the same point at the same time. Some people will have switched regimens because of tolerability issues. Some people will have switched regimens because of resistance. In our clinic, we generally feel anybody who's had a protease inhibitor 10 years ago was probably there because there was some underlying resistance. And so even though we don't have a genotype that's showing a resistance in the chart, we assume that somebody else might have one. And so we're always a little cautious about switching those people more than others. You also want to assess what is the likelihood that the person is going to be adherent to the new regimen. Just because it may be a 1-pill-a-day regimen when they're used to taking 2 or 3 pills does not necessarily mean they're going to be more compliant, because if there's side effects or issues related to the new pill, that will determine their compliance. We again want to assess medical drug interactions. And we use the evidence that we have before us to help guide our decisions. And that evidence usually is in the form of guidelines, which have been mentioned earlier in our talk. In Canada, we use the European guidelines more than the American guidelines because the European guidelines are generally more broad. You know, they have to appeal to a different or a larger group of people, a larger group of countries with different economic issues. And so we find them the most broad. And therefore, for us, it's kind of like almost anything goes. But, you know, that's good. And even in the guideline statement from the EACTS, their primary concern when switching is that it should sustain and not jeopardize virologic suppression. So when do we engage people in this discussion about switching regimens? Sometimes it's on the basis of the physician, and sometimes it's on the basis of the patient. Clearly, tolerability issues will come into play. Patients will talk about the side effects that they're experiencing, maybe some drug toxicities brought to the attention from the pharmacy, their ability to adhere to the medication regimen. We're always concerned about long-term side effects. You know, we all know about the bone and renal issues related to tenofovir, and then does that sort of drive us down a path to switching to a TAF-based regimen? Mental health issues, using a booster, for example, or using an integrase inhibitor may have some issues. And so we try to assess what the patient is on and look at the regimens that may or may not be appropriate for the person based on their current comorbidities. We look at the pill burden, we look at the pill size. We definitely want to avoid drug-drug interactions. And as our patients are getting older, we definitely want to minimize the number of medications that patients are taking, because we know that as we get older, we're going to start taking statins, we're going to take blood pressure pills, we're going to take diabetic medication. You know, so getting older does have its complications. It's also really important to remember that a single drug regimen of 3 drugs is 3 drugs. It's not 1 drug. And so we have to remind people that even though they're taking 1 pill, they are getting 3 different drugs in that. Pill burden clearly is an important issue. Now, one of the things to remember about pill burden is you can switch people from 2 or 3 different drugs to 1 pill a day. That's completely different. Or you can switch them from 2 or 3 drugs to 1 pill a day, which is exactly the same, just a different co-formulation. Regardless of how we do that, we follow the same rule where we will check people at the 4-week interval, regardless if it's the same drug or different drugs, because at least I kind of feel that it's not exactly the same. There are different buffering agents, there are different incipients, there may be some GI absorption issues. And so even though I'm giving people maybe the same 3 HIV drugs, I'm giving them a different formulation, and I will still check their viral load at the end of 4 weeks. The other thing to remember about this is cost. And so cost is really a seesaw battle here. In many cases, the cost might be different for a single drug regimen compared to the simple 3 drugs. But on the other hand, they may be on an older regimen, and by switching them to a newer regimen, even if it's a single tablet, it may be more expensive. So the cost can be higher, the cost can be lower, depending on drug plans, depending on government funding, and accessibility of certain drug regimens. Now, there's a lot of evidence out there supporting changing regimens. It's really important to remember that most of the clinical trials done for switching are pharmaceutical sponsored, and they're open label trials, and that in itself leads to a level of bias. As well, many patients who go into these studies are going in looking to get that new iPhone or to get that new drug, and when they don't get it and they're randomized to stay on their old regimen, they will drop out of the study. So it's really important to look at the study with a lot of detail and a very critical eye. So that speaks to the inherent bias that's done in any of the switch studies that are out there. It's also important to note that when we're talking about drug regimens that have over 90% viral load efficacy, it's next to impossible to get a superiority study. So the best you're ever going to be able to see going forward now is a non-inferior study, which is good, but it certainly does have its limitations. So here's one of those little controversies that are out there. And the controversy is when you're looking at switching regimens between one set of drugs and another, we assume that 3TC and FTC have equal viral efficacy, and we assume that tenofovir and TAF do as well. And I believe that they probably do, but there's not a lot of data out there that actually says that they do. But for the purpose of switch studies, we assume that those two drug regimens are equivalent. So now I'm going to show you some slides that are going to make you feel like this poor little cat. Okay, and for those of you who have OCD, do not make any attempt whatsoever to copy the information down. The slides will be posted on the website, but what I've done is I've summarized all the relevant switch studies so that when you do download the slides, you'll see the actual data in a relatively concise form. This is to show you not only the breadth of the studies that are out there supporting switches, but just to give you a level of comfort that the studies do actually work. So here we go. So switch studies to Dolutegravir, and there's really two big ones. There's the NEAT study and the striving study. But the general conclusion is if you switch the right people that are outlined in the study, you may or may not see changes in side effects, but you do not lose viral control. So switching the right patients to a Dolutegravir-based regimen is safe and effective. And the same thing applies to Bictegravir. I've outlined the studies here, and again, changing to a Bictegravir-based regimen is safe and effective as long as your patients fall into the groups that the studies were looking at. In Raltegravir, we have the switch mark and the spiral studies, and these studies were important not just because of the switch nature, but they really showed us the importance of patients' previous drug history, and they showed us the importance of changing to a regimen that was at least as viral efficacy as the previous regimen, and if the drug regimen had a lower resistance profile, it was very important to know what the other drugs in the regimen were and to take that into consideration. So the switch mark and spiral studies were probably more important for telling us what to do when we're switching regimens to look at the patient's history and previous drug history. That was probably their biggest impact on the whole stuff. In terms of non-nucleosides, for Doravirine, we have the drive shift study. For Etravirine, which we don't use very much in Canada, but some places in Europe may, there's 3 studies again outlining that the regimens work. Switching to Rilpivirine, again, this is all going to be summarized in the slide set, so save you from going through all these studies. My OCD allowed me to do this for you. Switching to TAF, well, there's a whole lot of studies, and I actually purposely put this on one slide in a really, really tiny font, because this is all based on the renal and bone toxicity or the renal and bone perceived toxicity that your patients may have. Because I'm not necessarily sure if somebody is 35 years old with good renal function, if they need to be switched to TAF. I'm also not 100% convinced about the weight issue with TAF. I'm not sure I buy the TAF is a returning to health argument. I'm not sure how concerned I should be about the weight gain that people see. I know that it is only maybe a kilogram or so for the first couple of months, and then it levels off. But, you know, a kilogram for the first couple of months and then keeping going level off is still 1 or 2 kilograms maybe that you don't need. So I'm not sure about that. And the fact that this is such a current subject is kind of reflected in the multiple studies and small font that this slide is in. We also have SWORD 1 and SWORD 2, which is a switch to a 2-drug regimen. So you can switch to 2-drug regimens as well. They are equally effective. We have Dovato, another 2-drug regimen, and I mean the big studies, Tango and Lamidol, showed that switching to this regimen is also safe and effective for the right person. And Cabenuva, the latte study. So there's a lot of studies that are out there that support this. It's really important to know your patient. It's really important to make sure that your patient is eligible for these studies based on previous drug history and what you know about their resistance. And so in conclusion, if a person has stable virologic suppression, There may be reasons to consider an antiviral regimen switch, especially if this is related to tolerability or convenience, because we know that goes to their compliance. Multiple factors should be considered before undertaking any modification to the retroviral medication regimen, including the past history, history of resistance, duration of virologic suppression, number of past regimen, prior medical intolerances and adherence. Assessing past treatment failures and resistance is especially important if the antiretroviral therapy regimen switch is being considered and you're going from a relatively high to a relatively low barrier to resistance. Or if that's the case as well, you want to make sure you've got other agents in there that can compensate for that. Select patients, those without previous virological failure, may be successfully switched from a boosted PI to an Integrase regimen. Again, in our practice, patients who are on boosted PIs and they're still on boosted PIs are probably there for a reason, and there probably was some non-nuke resistance in the background that may or may not be detectable, because that's just how we prescribe medications in our clinic historically. I've noted if you look at the monograph for prescribing Rilpivirine in treatment-naive patients, it's recommended for patients who have viral loads less than 100,000. The data in the switch studies showed that regardless of patients' baseline viral loads, if they were undetectable on efavirenz, you could switch them safely to Rilpivirine. So the high viral load barrier was only starting Rilpivirine. It was not switching to Rilpivirine once they're undetectable. I mentioned the controversy around TAF, and I think that still needs to be played out, whether tenofovir or TAF is the way to go. Certainly, there's a lot of two-drug regimens which are not only very effective for treatment-naive patients, but are also very effective and safe for patients to switch, again, as long as you're switching the right person. There are some dual regimens looking at ritonavir-based darunavir. This data seems to be promising, but there's really nothing out there yet suggesting this is the way to go for switching patients. And there is a little bit of work happening in terms of monotherapy for switch, but I really wouldn't even look at that stuff right now. I don't think monotherapy is clearly anywhere in the upcoming treatment paradigm. So with that, I'll stop and take any questions you have. Thank you.